Okay, hello, welcome back everyone. Now we have come to our last lecture for the day, which will be pharmacological considerations and complications, and will be given by our next speaker, Dr. Rabita. Dr. Rabita is a medical officer in Emergency and Trauma Department, Hospital Kuala Lumpur, and is part of the core team for ultrasound-guided regional anesthesia HKL. She graduated from Uni KL Royal College of Medicine, Perak, and has been in ED HKL for the past 6 years. Welcome, Dr. Rabita.
Assalamualaikum and a very good afternoon. It's a nice weekend, it's Saturday and it's the last presentation, and what I'm going to talk about is about pharmacological consolidation and also the complications. So welcome to the feature of RA in ED. So this is the presentation outline. So the background, pharmacological consolidation, common complications, post-RA care, and the follow-ups. Okay, first I'm going to talk about what is pharmacological consolidation, the background. So the local anesthesia is to prevent or relieve pain by interrupting nerve conduction by binding to specific receptor types of sodium channels in nerve and block the movement of iron through these pores. So this is our common types of a local anesthesia. There is a ester type and also emit type, but I'm going to focus more towards the emit type. This is the common LA that we use. For example, lidocaine, ropivacaine, bupivacaine, and also levobupivacaine. So for the lidocaine, it's a rapid onset of actions, but it is short duration. So usually we have a 1 to 2% of a lidocaine with or without the epinephrine, and the recommended maximum dose of lidocaine with epinephrine is 3 mg per kilo. Without epinephrine is 3 mg per kilo, with epinephrine is 7 mg per kilo. Next, I'm going to talk about ropivacaine. It is less cardiotoxic, and the recommended maximum dose for ropivacaine is 3 to 4 mg per kilo with or without the epinephrine. So usually we have 0.2% or 0.75%. So next, I'm going to talk about the bupivacaine. Usually the solution available is a 0.25% or 0.5%. It has a long duration. It has about 24 hours, and the recommended maximum safe dose for bupivacaine is 2 mg per kilo without epinephrine and 2.5 mg per kilo with epinephrine. Last is a levobupivacaine, is a less cardiotoxic compared to bupivacaine, and the recommended maximum dose is 2.5 to 3 mg per kilo. These example of vials of medications that available. There is a lidocaine, ropivacaine, bupivacaine, and levobupivacaine. In our emergency department HKL, our regional anesthesia practice, usually we practice RA using ropivacaine 0.2%, and the volume usually we use is about 20 mils for each block. If we want the duration of the block to be lasting much more longer, so we will increase the volume, or we will increase the concentrations, or we can add the adrenaline or epinephrine to make it last longer. This slide is actually talk about the type of anesthetic, the class, the onset, the duration, and the maximum dose. You can see and read from it. I can give the example of lidocaine. The onset usually 1 to 5 minutes. Lidocaine have a short onset of actions, but it didn't last longer. Usually it's about 30 to 90 minutes of effect. If you want much more longer effect, so we can choose either ropivacaine or bupivacaine. Even that he has a much little bit longer onset of action, about 5 to 10 minutes, but the duration for the LA to last, to give effect, is about 3 to 8 hours, much longer than lidocaine. Okay. Here I am just a brief about a factor determining the block quality. The block and set. The nearer the nerve, the shorter the time required to diffuse into the nerve. The block durations, the clearance rate of the LA influence the block durations and the block potency. The more lipid soluble the LA, the more potent it is. So when you want to do regional anesthesia, what type of local should you choose? So first, you must consider the durations. Next, you must consider the speed. So for the durations, what the factor determining the durations, the block duration? The first one is the nature of the drugs. Like I mentioned before, lidocaine have a short acting compared to the bupivacaine is a long acting. The drug concentration, the higher the concentration, the longer the block. The drug volume, the larger the volume, the faster the onset and the denser the block. And you can use the additive, example like epinephrine and sodium bicarbonate. So it will speed the onset and also the prolong the block, and also type of block. The leg block, example, I give example, leg block lasts longer than arm block. So these tables show that this comparison between the speed on the type of local anesthesia, the speed of onset, and also the duration and toxicity. It's similar as previous tables, but it's just showing that lidocaine have a speed of onset. The onset of action is much more faster compared to the ropivacaine, but duration is much more longer, much more shorter compared to the ropivacaine. So you can show there is a comparison between the toxicity also. It's just words to live by. Life is pain and the enjoyment of love is anesthetic. Okay. Next, once you give the block, must be have a complications. So here I'm going to talk about complication of the regional anesthesia block. The most and the life-threatening adverse reaction is last. What is last? Local anesthesia systemic toxicity. Is a resulting from the LA reaching significant systemic circulation levels. Last always occur within minutes of injection of the LA. I'm going to talk much more after this. So next is the nerve injury. Nerve damage. A nerve damage injury after RA is regarded as major complications. If the injury is severe, may take weeks or even months to recover completely. Direct nerve injury is evidence when isolated nerves are exposed to high concentration of LA. The symptom, for example, pain, sensitivity, tingling or pricking sensation, burning sensation, numbness or weakness. And the third one is allergic reactions. It's a rare to have allergic reaction towards LA, but anaphylaxis more common with ester LA, some to the preservative, such as metaparaben, includes in with the LA. So next is hematoma. Also rare, less than 30 cases. The most common risk factor appear to be procedural difficulty or concomitance with anticoagulants or antiplatelet therapy. So rarely neurological dysfunction, but more typically visible bruising, local tenderness, decrease in hemoglobin, hematocrit, or relatively hypotension due to the blood loss. So next is pneumothorax. Common when you do a supraclavicular brachial plexus block or the infraclavicular brachial plexus block. So this is from this slide, I'm going to talk about a more elaborate about the local anesthetic systemic toxicity. Is either it can come up with the CNS, central nervous system toxicity, or cardiovascular toxicity or miscellaneous. So for this central nervous toxicity, patient can come with the tongue numbness, lightheadedness, visual disturbance, auditory disturbance, convulsion or coma. For the cardiovascular toxicity, it can come with conduction disturbance, myocardial depressions, arrhythmia or cardiac arrest. If patient come with last symptom or you detect a last symptom, so what should you do first is to stop injection and call for help. So if we can do the A, B, C, D, first start, we can give the ventilation support, cardiovascular support or seizure control. For ventilation support, ventilate with 100% oxygen, avoid hyperventilations, advance airway if necessary. For cardiovascular support, treat hypotension, arrhythmia, cardiac arrest as per SLAS. You can continue the CPR throughout the treatment with the lipid emulsions. Reduce epinephrine bolus to the 1 microgram per kilo. Avoid vasopressin, calcium channel blocker, and also beta blocker. For seizure control, benzodiazepine preferred. Avoid large doses of propofol. So, last rescue kit, you must construct the NS. There is a therapy lipid emulsion for patient more than 70 kilo. You should give bolus 1.5 ml per kilo over 2 to 3 minutes and then continue with the infusions 0.25 ml per kilo per minute, ideal body weight. If patient less than 70 kilo, bolus 100 ml over 2 to 3 minutes, infuse 200 to 250 ml over 15 to 20 minutes. Reassess back if patient remain unstable, rebolus same doses or double the infusion rate. Okay, rebolus to a maximum of 3, including the initial bolus. Okay, leave about 5 minutes within the each bolus. So, okay, additional recommendations, continue monitor at least 4 to 6 hours if cardiovascular events, monitor at least 2 hours after initial CNS events, and do not exceed 12 ml per kilo in lipid emulsion. Total volume of emulsion can approach 1 liter in a prolonged resuscitations more than 30 minutes. Okay, monitor for lipid emulsion induced pancreatitis also. So, okay, this is the algorithm that I'm taught from the previous slides. Okay, next we're gonna talk about suspected nerve injury. So this is the algorithm. Is you have a patient with suspected nerve injury, have the symptom of pain, paresthesia, numbness, weakness, or abnormal sensation. So beyond usual duration of specific block, so you need to observe patient back and do a proper assessment, especially for the full neurological examination. So, if patient have mild symptom or resolving symptom or persistent neurological deficit, so first you must give reassurance and you must you must review patient in a follow-up clinic. In here, we usually practice to call patient the next day if patient discharged or visit patient if or go to see patient at the ward, inside ward. So ask patient whether patient have any symptom. If patient persist symptom, usually give and review patient in 4 weeks time in the follow-up clinic. If no persistent symptom or so there is no need for further follow-up. So you can discharge this patient. If the symptom persists, we need to refer to neurologic team for nerve conduction test and electromyography or consider further imaging. So if you have a severe symptom of progressive neurological deficit or persistent motor deficit, we must refer to respective team like surgicals, neurological teams for nerve conduction or pain control team, and consider for the image to look space occupation or for emergency decompress. We must establish a further diagnosis and discuss with patient regarding option of management like conservative a physio, a medication, or surgical, and update patient perspective constantly and follow up as appropriately. Okay, this is what we do for the procedure care. Once we block the patient, so we assess for complications. If no complication, usually we will discharge from RA with the advice. And if patient admit to the ward, we will do the assessment in the ward within 15 to 24 hours whether the patient have complication or not. So if patient has the symptom that I mentioned above, last nerve injury, allergic reaction, pneumothorax or hematoma, so we do accordingly to the algorithm that I mentioned previously. So if a patient have the complication, optimize the airway and oxygenations, optimize cardiovascular status, and assess neurological functions. So refer to designated RA complication I mentioned before, the protocol. And if patient, the further follow up, patient have no more complications, so we shall discharge patient from the RA follow up. Okay. You can see the examples of our follow-up forms. Here you can see there is a patient name and IC, the date that we do the RA, the type of block and the indications. Assessment of block, usually we will ask patient about the pain score, the function pre and the post RA. And the column and below that you can see the if patient have the symptom or complications. And if patient don't have any symptom or complications, so you can put inside the column the outcome where the patient is discharged or further evaluations. This is the end of my presentation. Here the reference you can look up. So I hope that you find this course, our regional anesthesia course, interesting, and you can apply at your hospitals, especially in ED. So happy weekend.